So I want to introduce you to Dr. Matani. She is an associate professor of medicine at the University of Miami, and she is a medical oncologist. Her focus is exclusively on breast cancer patients. She's also a member of our medical advisory committee. We're going to have a Q&A session with her, and then we will bring in Greg Garber, as Janine said, who is a social worker at the Sidney Kimmel Cancer Center at Thomas Jefferson University in Philadelphia, another really great friend to Living Beyond Breast Cancer, and he is also part of our medical advisory board. So now that we have those introductions complete, I am going to ask Dr. Matani to just start by giving us an update of what's going on for the metastatic community now that we're living with COVID. Hi, Dr. Matani.
Hi, Jean. Thanks for having me. I wish I could see you all in person. I'm also very disappointed that I'm not in Philadelphia this weekend with all of you. But it's so great to see this program organized virtually, and I'm happy to be a part of it. So I want to keep my comments really brief because I do want to make sure that we have time for questions from everyone who's dialed in this morning. In terms of breast cancer care in the time of COVID-19, with a special emphasis on metastatic breast cancer, I'd just like to remind all of you that although we're dealing with this unprecedented time, this pandemic that's really changed our lives so dramatically, I'd like to remind all of you of a positive note, something positive, that we're still making progress in the treatment of metastatic breast cancer. We're extending survival and working towards offering treatments that not only improve outcomes, but with an eye towards tolerability of those treatments. Many of you may have heard the great news that we got just yesterday, that we have an approval now of a new oral drug, tucatinib, in combination with capecitabine and trastuzumab for patients with HER2-positive breast cancer. This therapy has shown a survival benefit even in patients that have metastatic breast cancer to the brain. So I tell you this just to remind you all that even in the face of this pandemic, we're still moving forward with approvals of new therapy and still doing the hard work that we need to improve outcomes for metastatic breast cancer patients whenever possible. Our research is continuing. Just to give you a little bit of background about what I'm dealing with where I am, I'm here in South Florida. We're about to hit our peak in the next week or two, and at my cancer center and at centers across the country, we have put preparation protocols in place to keep you all as safe as possible and help slow the spread. So some of these Jean already mentioned, no visitors coming into the cancer center. I know this has been tough. It's all in the interest of keeping everyone as safe as possible. We're making sure to screen everybody that's coming into the cancer center and making sure that patients are appropriately tested when they meet criteria. And the other thing that I think has been really very helpful, we've used at our center, and I know this has happened across the country, is the use of telemedicine. So this is a really great program that we have in place because we are fortunate in this day and age to have multiple platforms like Zoom, FaceTime, Skype, so that we can stay connected with our patients and that all of you don't feel that social distancing equals social isolation for you. So we really do want to stay connected to you as much as possible and make sure that we're working through whatever we can virtually. So I'll just close by saying that I recognize that this is a difficult and stressful time for all of you, but I want to assure you all that the oncology community is committed to ensuring that your care continues uninterrupted as much as possible whenever safe to do so. And the alterations that we're making in your care are really being done in the interest of keeping everyone safe. So with that, I'll just open it up to any questions.
Thank you, Dr. Matani. And I have been speaking to medical oncologists around the country, and all of them have been very reassuring in that you are looking at every patient and making decisions about who can wait and who needs to be treated. So just to jump into the questions, there's several questions around scans and regular tests. So one person's PET scan was canceled, and obviously that's causing anxiety. And other people are asking, are bone scans and CT scans now considered elective procedures for this?
That's a great question. This is something we're dealing with every day because every week I get a list of scans, patients that are scheduled for scans, PET scans, bone scans, CTs, and I'm asked whether or not it would be safe to delay that scan. And so this is not being done uniformly across the board. It's really being individualized. So if I have a patient who I have the sense that the treatment that they're on is not working, and I really need that information to help me make a treatment decision, we're going forward and allowing those scans to proceed. But that's a very different situation than if you've been on the same therapy and you're doing well on it, and we really do have a sense that you're responding to that treatment, and the scan is being done more just to confirm what we already know. In those situations, we're weighing the benefit and the risk of having you come in for that scan. So I don't want to make any decisions that are across the board, and I think many of us have felt the same way. We are individualizing our treatments. So if it's important to get the information, the scan is proceeding as normal on time.
Great. So patients should feel confident that their doctors, again, are making decisions specific to their case.
Yeah, we're making those decisions. There are not administrators that are across the board coming and saying all these scans are canceled. That's not the case. We are very intimately involved in these decisions, and we are making individual decisions for each patient.
Thank you. So there are several questions about who is more immune compromised than others. So for those that are on Ibrance or another CD4K6 inhibitor, are they at higher risk? Because it seems like there's been some conflicting information.
Yeah, so just recognize that the neutropenia that develops as a result of CDK4/6 inhibitors is not the same type of neutropenia that is the result of chemotherapy. So that being said, a low white count in this situation, we are concerned about the risk of infection. Without COVID being in the picture, we used to tell patients that the risk of febrile neutropenia or fever with a low white count and getting hospitalized with those kinds of complications is actually very low with CDK4/6 inhibitors. So although this is a normal outcome of taking these drugs, it's more of a paper toxicity. We see the low white count, but people don't end up in trouble with fever and other complications very often. However, with the situation now with COVID, we know that anyone who is immunosuppressed with a low count would be considered at higher risk. So for these patients, we are still cautioning them that they are immunosuppressed, and I think that's across the board a recommendation that's being given.
Thank you. So this is a longer term question. I'm not sure you'll have the answer, but several people have asked, for the metastatic community, will they not feel safe until there is a vaccine?
Yeah, this is a tough question. I think that not just for metastatic breast cancer patients, but all cancer patients and all patients that are immunosuppressed, we know that we're most concerned about the risk of infection in these immunocompromised patients. I think that a vaccine is something that all of us are looking towards, but realistically, from my understanding of where we're headed, that's not likely to be the case for another year or even a year and a half. So in the absence of a vaccine, I think what we are going to have to do is move towards having a better understanding of who has contracted the infection and may be immune because of antibody detection, and more testing. So recognizing who should be at home quarantined because they're positive versus who is immune.
Yeah, thank you. So several people are also wondering if their treatment is being changed. So if they had been having maybe IV chemotherapy and they're being switched to an oral therapy, if you could address that.
Well, I think that is tough to address across the board. I think that in individual situations where there may be a good option that is safer, an oral treatment, I think it's something that we're considering. It really depends on what therapy they're receiving. There are certain drugs. For example, IV-5FU that is in the colon cancer community where we use that drug, infusional 5FU, quite a bit. A lot of patients may be getting converted to oral 5FU, which is capecitabine. So there's a very easy conversion. In breast cancer, there may be a switch to an oral regimen just because it doesn't lower the count as much, but it's being taken into account whether, of course, that regimen would be considered equally appropriate or effective in that therapy, in that setting.
Okay. And I know that it's an individual question.
Sure.
So a lot of people are asking about, how do they make sure they're doing everything they can to stay safe, and including what their family is doing. And also when they have to, we're all being told to shelter in place, but we realize if you're in treatment for metastatic breast cancer, you can't follow that so easily. You have to go to the hospital. So what can they do to just make sure they're being as careful as possible?
That's a great question. So, this is something that patients that are on treatment, as you mentioned, they can't shelter in place. They have to go out. The times that they do go out, we want to make sure that everybody is following the CDC recommendations of wearing a mask, hand washing frequently, recognizing that we're hoping to do as much as we can via telemedicine. We've had a lot of patients become a little bit uncomfortable with telemedicine and insisting on coming in because that's what they're used to. But again, recognize that every exposure that you have is putting you at increased risk and you're immunocompromised. So I would say what you can do to keep safe is to follow the recommendations of your physician and trust that if they're telling you not to come in, that you should adhere to that and become familiarized with telemedicine as much as possible. Of course, frequent hand washing. For those who are obviously not able to self-isolate to the point where everyone has a family or someone that they're living with, if you can isolate in your home, if you have someone who is being exposed to multiple people and then coming back home and you're immunosuppressed, that actually, or of course, would put you at risk. So trying to self-isolate within your home would also be a useful strategy.
Okay, so
I know it's
lots of things. Yeah, a lot of things to think about, and we know many people have young children or they may have an older relative in the home. So we do understand this is really a very, very challenging time. So some people are asking when the vaccine is available, which we all want quickly, will it be alive or dead, or will it be safe for metastatic patients to take it? And connected to that question is, do you have any information on how metastatic patients are doing if they actually contract COVID-19?
So I can't really make too many comments about the vaccine. I think those studies are ongoing, or that research is ongoing, and obviously we'll all have to look at the vaccine and understand whether it's going to be safe in cancer patients or not. I think those things are things that I'm not able to comment on now because we just don't have more information. This question about how cancer patients do who do contract the virus is also something that we're gaining more information on. And there's very limited information. In China, actually, they did do a nationwide analysis of the patients who contracted COVID, and they looked specifically at cancer patients. And it was actually a very small number. It was about 18 cases. So only 1% of the entire population. So you recognize the numbers are very small here, looking to see how those patients did specifically. We know that immunosuppressed patients or patients that are older, have comorbid conditions, they're likely to do more poorly with a COVID-19 diagnosis. But again, this is something that we're collecting more information on.
Right. It's so hard not to be able to know, but it's a very fluid situation.
Mhm.
So not surprisingly, there are several questions about the status of clinical trials. And I know we've all read different things about trials being stopped. So if any information you can give on that would be helpful.
Well, I would say that your concern about trials is one that, as a clinical cancer researcher, my concern and the concern of my colleagues is really very focused on this area, because we want to ensure whenever possible that the trials are continuing. Unfortunately, because of the current situation, many studies have been put on hold. And because of that, we've really become very highly selective in allowing patients to go on studies, because remember, many of these trials involve a lot of testing, a lot of back and forth from the cancer center for diagnostic tests, echocardiograms, EKGs, and again, that places you all at risk. There are patients that are still going on trials, especially when there are no other good options. And I would say the sponsors for the studies have been very accommodating. They've allowed us to do telemedicine visits whenever possible. If there's an oral therapy, they've allowed us to actually ship the treatment home to patients. So we've had to adapt to the current situation, and some studies have been put on hold, but not across the board. So we are still going forward, especially in cases where there's really no other good option for that individual.
Thank you. Because I think there is really a concern that will this pandemic impact the pace of research and discoveries for metastatic breast cancer.
Yeah, it's our concern as well. I mean, we are all committed to cancer research, and a lot of us have devoted our lives, our careers, work into some of these protocols, and we really are very committed to having that work go on uninterrupted. But unfortunately, the current situation has made it such that we're always balancing risk and benefit, and we have to weigh very carefully the risks associated with some of these novel treatments.
Thank you. So just a question about telemedicine. I know this is something that the technology's been there for a long time, but it wasn't really being utilized. So I'm wondering, from your perspective, how is it going for you in having to convert from seeing your patients who you probably have strong relationships with? And then also, how can patients best prepare for those telemedicine visits?
Yeah, actually, I was a little hesitant first when telemedicine was coming about, because, as you mentioned, so much of what we do in oncology is really involved in that personal connection that you have with the patient, and it's hard to do that remotely, especially for a new patient. I've still struggled with that when I haven't met the person in person and I have to actually have that first visit via telemedicine. So that's been a bit challenging for me, but on the flip side, I think that in a way it's been really great to see people in their own environment. I've gotten to, meet family members that haven't been able to make it to visits. I've gotten to see people with their children and their pets at home. And so it's been a little bit nice in that way, because it's allowed me to connect on a different level. And, I think a lot of things that we can work through via telemedicine are things that necessarily don't have to mean a visit to the office. So it's been quite an efficient way to take care of patients. And I think going forward, I hope that some aspects of telemedicine are still available to us after the pandemic, because I'll wait to hear what everyone thinks, but some of my patients have told me that they actually like it a lot and they prefer it. In terms of what to do to be prepared, if you're a new patient, it would be really, of course, helpful to have everything, all your records, make sure that the new provider that you're making that connection with has everything available. You have a list of all your medications handy, all the things that you would have brought into the office, a list of your questions, so that the visit can be as productive as possible.
Okay, great. We are going to bring Greg Garber into the conversation. Again, Greg is a social worker, and we know this isn't just a Again, it's an economic crisis, it's a medical crisis, it's a health crisis, it's also an emotional crisis. So we want to make sure we get that perspective. As all of you can see, we have another poll up, so we would love for you to take a minute and fill that out. We absolutely want to know what's on your mind. So, Greg, here's a question I've been getting from a lot of women, men in the metastatic community, which is that they already feel like they're on limited time. You know, and maybe they've already had to isolate because of being immune compromised even before COVID. But now they feel like they're not going to be able to get to see their parents, their grandparents, their friends, their family, maybe a trip. And how do you help them reconcile with this loss on top of a loss?
Sure, Jean. I think it's a tremendous question, and it's something we grapple with all the time as we all kind of, to use the word, pivot into this kind of virtual world that we're finding ourselves in. And it is obviously less than ideal. However, there are tremendous numbers of opportunities to connect virtually with people. And while it's not the same as being there, it does help relieve some of the isolation and some of the loneliness and some of the loss that everybody has been experiencing. I have been doing this for about 25 years, and I have never seen anything progress in terms of developing programming and resources and opportunities for patients and caregivers and children and others and providers in such a short period of time. And so I'm really encouraged by some of the feedback that we have gotten on a number of our virtual programs. In all of 2019, and I manage a pretty big program, we had 80 virtual attendees at our programs throughout the year. Most people obviously came in person. In the past 2 weeks, we've had 190 attendees, and we solicit feedback from everybody, and we have gotten tremendous feedback. And the tenor has been that people are surprised by how nice it felt, how close it felt, the intimacy even over a screen. And so while, you know, it's not like being there, it is something, and it is the best that we can do right now. And the more that we're all able to keep ourselves safe and okay, the more likely we will get to a point where we can feel more comfortable being able to get back to the way that we did things before. And you know, to echo Dr. Matani, I think that the medical field has taken a tremendous approach to this extraordinarily steep learning curve, and literally every hour something changes in the course of my day, where I learn something else and something that's developed and something that's working to make people able to connect with each other more, to keep people safe when they're going in for treatment. All of these questions I've been reading through the Q&A, even though I know I'm not supposed to, and I get it. I hear all of these things every day about delaying scans, about clinical trials, about telemedicine, and it's do know that we're learning very, very quickly from our experiences. And I'm hoping and praying and thinking that we are going to be able to help people and support them, and in ways that we never thought possible. Seeing a therapist via telemedicine, or sharing a Easter or Passover or whatever you celebrate. I mean, it's been nice to kind of see that does provide something. And I think the more that people can do that, the more the sense of isolation can be reduced, at least, you know, for now.
Yes, and I do think if there will be hopefully some good things that come out of this, and maybe telemedicine will be something that will continue, because we know that for a lot of people it's hard to get to appointments, it's expensive, there's all kinds of things, can have more regular communication. So we did get the results of that poll, and it seems like, as you can see, the biggest concern is that the metastatic community really is concerned that they're going to be treated differently because they are living with metastatic breast cancer. So just to add on to that, Dr. Matani, because this question has popped up a bunch of times, and I don't think you're going to be able to answer it, but I'm going to ask you anyway, which is, people are concerned that when there is a vaccine, that it will be rationed, and will they not be considered a priority, or will it be disseminated in a way that they might lose out?
That's a really tough question for me to answer in the absence of having the vaccine or having any information about the vaccine. But I would be highly surprised to think that it would be rationed in such a way that people would be triaged and they would be, thought to be any less important. I just don't get the sense that would be the approach taken. Of course, that's not based on any data or evidence. That's just more of my gut instinct.
Right. And I think it's been, because testing's been so challenging in this country and who gets tested and who gets the quick test, I can see that being a concern. Since we only have Dr. Matani for a few more minutes, I do want to ask a couple more questions of you that are specifically medical. Since we brought up the new approval in HER2 positive metastatic breast cancer, people are asking a little bit more about that new therapy. So if you could share.
Sure. So the approval that we got just yesterday was for an oral drug called tucatinib, and the drug was approved in combination with another oral therapy called capecitabine and trastuzumab or Herceptin. And this therapy was given to metastatic breast cancer patients who had progressed on pertuzumab and Kadcyla or TDM1. And the unique thing about this trial, the trial was looking at tucatinib, capecitabine, trastuzumab versus placebo, capecitabine, and trastuzumab. And the addition of tucatinib improved progression-free survival, so the amount of time that it took for the cancer to progress, and most importantly, it improved overall survival by 4.5 months. But the most impressive thing about this trial was who was allowed on the study. So many many metastatic breast cancer trials exclude patients that have active brain metastases. And this trial allowed patients on with brain mets that were either stable or even stable and progressing. And the therapy actually helped those patients, even those that had active brain metastases. So this represents a really new, important treatment options for these patients. And the other thing that I want to emphasize is that tucatinib is a very well tolerated drug. There is a risk of some elevation of liver function tests and diarrhea as the main side effect, but generally very well tolerated, and to have a survival benefit is always something that we are very impressed with.
Thank you. And Living Beyond Breast Cancer we may have already written about this, but check our website. We'll have more updates and we'll continue to do that. So there's a lot of questions, and I think you both can answer this, but I'll start with Greg, which is what about people that aren't so expert with technology? They might have a flip phone. They might not have a computer in the house. They might not have great internet access. And we are asking people to rely so heavily on this technology. I think we call this digital literacy. So Greg, why don't we start with you for your thoughts?
Sure. This has been a huge focus of ours. Our institution started doing telemedicine visits about 6 years ago, and we all kind of thought it was a little before its time, but we yielded, and now it has really worked out in spades. And from very early on, we realized that there are people who have flip phones. And I have to tell you, a flip phone is not a bad thing. Typically, the battery lasts much, much longer than an iPhone. However, a couple of things I would say to people who are challenged by digital literacy, and we formed a task force at our cancer center to reach out to these patients to see if it's at all possible to get them connected with telemedicine. And for those that we can, that's great, or help them problem solve. If there is a family member or a relative or somebody else who lives with you who is able to access that is definitely an option. There's no reason why a telemedicine visit could not happen on the app logged into your account. And most cancer centers who are doing telemedicine have somebody who can give a little tech assistance. However, and I have to credit, government, the federal government for this, Medicare has made a tremendous effort to relax the laws and regulations as they relate to telemedicine. And so while it is not ideal, visits can be conducted via telephone. We try not to start there if there's any way that we can get people connected, but that is a viable option. And for somebody who doesn't urgently need to come in and for whom a telephone call would suffice, our cancer center has been doing that and kind of recognizing that as a way to keep people safe and as a way to get information and a way to connect with patients. So I wouldn't give up on it. I think it is worth seeing who in your immediate environment might be able to do that. And if there is even a small propensity to be able to use a smartphone or a tablet, that's great too. I mean, literally, you can go on to Amazon and get a $28 Samsung or Android-based phone without any internet, without any cell service, connected to Wi-Fi, and get an app on it and do that. So there are lots of ways to get around this, and more to come, but I think that it is very reasonable to ask for a phone call in lieu of a telemedicine visit.
Okay, and we covered this in one of our videos, and we'll continue to cover it because I think this is something we're going to be dealing with for a long time. But before we let Dr. Mitani go, someone asked, I think, a really thoughtful question, and I want to get your opinion about it, which she says, realistically, when you are balancing quantity of life versus quality of life, and in the future seems like self-isolation won't be realistic to follow for a very long time. So what guidelines are you giving metastatic patients for having some family visits and some connection?
Yeah, I agree. I think this is a great question. And this whole pandemic has really shined a spotlight on a lot of issues. And again, this whole thing of balancing quality versus quantity of life for metastatic breast cancer patients is something that we should actually be putting at the forefront of our minds in our discussions in usual times. But because of this whole issue surrounding the pandemic, it's really brought that to the forefront, which I would say is actually a good outcome because it should make us reevaluate these balancing the balance of quality of life versus quantity. I think, to your point, to the person, I think her name is Andrea, who asked the question. I think it's a great one. I think that for patients that are metastatic that have to continue on treatment, we're obviously not asking you to self-isolate to the point where you don't have the support system in place that you need. We have to have you have that, or have your family around you. It's been really challenging for this no visitor policy because so much of the support network that our patients have are the family and friends that come with them to the visit. So if we're not allowing them in the office, I don't think that it's reasonable to ask people that are at home with their family to not be in touch with them at all. Obviously, you take the precautions that you can, frequent hand washing, wearing a mask when you're out in public. If you have a family member that is exposed to a lot of people because of something that they do, trying to at least, create some separation within the home, that's the best that we can do. I mean, it's just not possible to do this 100%. I think we all recognize that.
Yeah, I agree. And I know we all have issues. I mean, I have a father who's almost 91, and he said to me the other day, I think I'm going to be in the house until next summer. And I thought, am I not going to see you until next summer? I mean, are these the kinds of things we're grappling with? And I think we'll have to make decisions along the way. Mm-hmm. Dr. Mitani, I want to thank you so much. I've been interviewing a lot of doctors over the last 5 weeks, and I have been ending all my interviews saying thank you so much. We are so aware at Living Beyond Breast Cancer that the healthcare community, you really are soldiers in this war, and you didn't really sign up for that. And we appreciate the risks you're taking and what you're doing to protect yourself and your family, and also be there for your patients. So please know we're all standing with you and wishing you well.
Thank you. I appreciate that.
Okay, take care.
Take care.